Okay, now we are going to start liver, gallbladder, pancreas, and those issues. So, jaundice. Let's talk a little bit about jaundice. Jaundice can be caused by different things. Patient has hepatitis. Patient has toxic liver. Patient can have trauma to the liver, cell damage. A wide range of things can cause trauma or jaundice. So one of them, for example, is hemolytic jaundice. So basically, you just have an increased RBCs. This can be brought on by sickle cell anemia, could be brought on by a lot of blood transfusion reactions. Then hepatocellular jaundice is like hepatitis, cirrhosis, carcinoma, or obstructive jaundice, which the flow of the bile is obstructed. So you have things like pancreatic cancer, strictures in your liver, fibrosis, cholangitis, which is the inflammation of your bile duct. So what ends up happening is you have an increase of bilirubin that ends up in your blood. You can't get rid of it. Shows up in your skin. So to have jaundice apparent in the patient, you need up to 3 times, 2 to 3 times the normal bilirubin level for that to happen. So here's a picture of jaundice. Obviously the patient on the right has jaundice, patient on the left does not. One's yellow, one is not. So that's jaundice. Complication of jaundice is obviously the yellow, but that's really not the problem. The problem is sometimes the jaundice can cause itching on the skin because of the salts that get in the skin, so itching could be an issue. The other issue is doesn't hurt, but your urine turns very dark brown, almost a coffee ground color. That's just normal. So let's take a look at a picture of what's going on with these organs. So basically, you have down here in your duodenum an opening called the sphincter of Oddi, ampulla of Vater. That's where your gallbladder secretes the bile that comes down. That's also where your pancreas, you have enzymes that need to be there. Also, you have your liver, so part of that ends up being the common hepatic duct with the gallbladder, so you have that flowing down. So if anything becomes obstructed right in here, it can cause a backup of problems from the liver or a problem from the gallbladder. A gallstone can come down here and it'll be blocked, so now you've got a problem there. If anything is blocked, you've got your bile and everything is going to start backing up, which can cause an inflammation, painful. So everything should come out right here at your sphincter of Oddi. Here's your pancreatic duct. So even a gallstone can come down and block here, or right here in this little space before it goes out, it could come in and it could block the pancreatic duct. So all these things are interconnected. That's why lots of times patients have a problem with the gallbladder, depending where the stone or what's happening. It can affect the liver. Problems with the liver can affect the gallbladder. Problems with the pancreas because of that bile duct can affect the other organs. So here's a picture of your liver and the gallbladder. Here's a picture of the pancreas. These are all taken inside a patient laparoscopically with a scope. So cirrhosis. Cirrhosis basically is a liver that's gone into failure. So some patients with cirrhosis of the liver, if it doesn't turn around, will die from this. So it can be brought on by alcohol, drugs, toxins. If a patient ODs on Tylenol, and that can cause you to go into liver failure, so cirrhosis. Hep C is the most common infection because it's chronic, so chronic Hep C infections can cause cirrhosis over a long period of time. Cirrhosis comes on usually very slowly, unless you do something like takes tons of Tylenol. Then you have what's called fulminant, Fulminant, fulminant failure. Bile duct obstruction is another thing. So cirrhosis basically is very chronic progression. It basically is going to degenerate and destroy your cells. Those cells, once they're destroyed in your liver, your hepatocytes, then what ends up happening is they become very fibrous. They build up nodules. Blood can't flow through. It can't do the filtering that you need. Another drug that can cause cirrhosis is the patients that have TB and they have to take isoniazid. INH can also cause cirrhosis. Toxins, obviously if a patient has gold infections, tetrachlorocarbons, things like that. So you could have an infectious cirrhosis, or you could have one caused by drug and toxins, and they're not infectious. So keep that. Just because someone has cirrhosis doesn't mean they're infectious. Okay, alcoholic cirrhosis. That's basically the most common. 50% of all cirrhoses caused by alcohol. Alcohol causes that accumulation of fat in the liver cells. Liver cells can't do it. Somebody who has alcoholic cirrhosis, it is reversible if they stop their alcohol intake. That's very difficult for some patients to do. So that injury to the hepatocytes causes the fibrous tissue, interferes with your circulation. Another word for alcoholic cirrhosis is Lennox cirrhosis. So liver actually works pretty well if it can regenerate. And so post-necrotic necrosis, that is drugs and chemicals. So like I mentioned, acetaminophen, INH, gold, and other kinds of chemicals, people that work with chemicals in their job description. So people that have cirrhosis also have an increase of cancer. There's a type of biliary cirrhosis. So that common bile duct, around the bile ducts, the cells, it can be destroyed, and so now you have a cirrhosis. So it's most common post-hepatic biliary obstruction is the most common cause of that. So you don't have cirrhosis in the liver, you have cirrhosis in the biliary duct. Although your bile is backing up into the liver, that's causing jaundice because the liver's not going to work. So this is more common in women. So just another form of cirrhosis. So early signs of cirrhosis. Cirrhosis is insidious. It means it comes on very slow. So anorexia can cause weight loss. Somebody doesn't feel like eating. Flatulence, dyspepsia, nausea and vomiting, change in bowel habits, we've talked about that before, and a lot of abdominal pain. If someone does not feel like eating, they need nutrition, so that's a big issue for these patients. Also, the other issue is the nausea and vomiting. So diagnostic studies. Well, at the beginning of any kind of cirrhosis, someone will have elevated liver functions tests. So alkaline phosphatase, aspartate, aminotransferase, aniline aminotransferase. Those are all the ones you see on the lab report, ALT, ALS. So those would be elevated. You would have a decreased albumin and protein. Why would you have decreased serum albumin and protein? And why would you have prolonged prothrombin time? So consequently, bilirubin cannot be metabolized. So later signs of jaundice, skin lesions. The skin really takes a beating. You also have hematological problems. Um, One of those has to do with your clotting factors. Endocrine problems. The liver does a lot of work with endocrine things, so estrogen and testosterone, you need a working liver to manufacture those. So if that's not working, what kind of symptoms would you have? Peripheral neuropathy, it's going to damage nerves. So peripheral neuropathy could be an issue for those patients as well. So cirrhosis, biggest complication for cirrhosis, over because it is insidious, is you have portal hypertension. Portal hypertension, basically, since the blood from the veins cannot flow through the liver because of the fatty fibrous nodules and the scarring, it backs up and it causes pressure in your portal veins. So those back all the way up, and those are the patients then that have varices, esophageal varices or gastric varices. So it builds up pressure. These patients are at high risk of having these varices bleed. So that's a major complication. So esophageal varices, they can ooze or rupture. Patient strains, bears down if they have hypertension to begin with. If they eat certain foods that are not chewed up well enough, that can injure and cause a leak. So what kind of patients, what does a patient look like that has esophageal varices? So what do we do if you have active bleeding? Well, we hopefully can get them to the emergency room and get them to GI procedure and do a banding ligation sclerotherapy, which we talked about. During this procedure, you want to monitor your airway breathing. If they're bleeding, what's their H&H? Do they need blood? Octreotide is a sandostatin. It's not a statin drug for high lipids. This one basically constricts for bleeding varices. These patients may need to be on propranolol, which is a beta blocker, so they need to be on these to lower your blood pressure. And because of the bleeding, if they can't get to surgery in time, they may have that Senstaken-Blakemore tube. We talked about that. That basically causes a tamponade. These patients that have that, you have to deflate the balloon for 5 minutes every 8 to 12 hours or per policy, so the patient doesn't have any necrosis caused by the pressure in the esophagus. You also should be aware they should have vitamin K. Vitamin K is an antagonist and will stop bleeding, so it'll increase your bleeding time. So here's pictures of portal hypertension. Normal esophagus looks really good. Notice these varices are all inflamed. All here, all these big things here are varices. Those can open and bleed. Here's another one. Go see how blue that is. Varices and the esophagus.